Dear Pure Urology Facebook viewers, good evening one and all. After some gap, we are restarting this week with again a stone topic, that is inferior calyceal stone, that is also RIRS, not PCNL. A lot of discussion happens last 3 years. RIRS is almost equal with PCNL in stone management in less than 2 centimeters at least. But some controversy is there for the inferior calyceal stone, because inferior calyceal stone is the one which is easily approached with PCNL, but not the same with the RIRS is the general discussion, because the scope has to bend against so many angles, reach the stone and then powder, whether the powder will clear or not, whether residual fragments will be more or not, whether the scope gets damaged, how big the stone can be tackled with the RIRS, whether the basketing helps or not. This is a big subject. Last 10 years, we are discussing. One change is small scope, one change is small laser fiber, one change is high power laser, all these making things different. So to listen that, I have my friend, Dr.Anil Shrestha from Nepal. For last nearly 10 years, we have been friends. We attend the conferences. The amount of knowledge he has in the management of the stone through RIRS, PCNL is enormous. He has experience with 100 watts laser, 30 watts laser, thulium fiber laser, and he has published many papers, and he is a faculty invited in various national, international conferences, including at my place at Hyderabad. 2 times he has come and demonstrated a nice RIRS. With this, I like to introduce him officially through this slide. And today topic is video-based surgical presentation on RIRS in inferior pole calculi. Dr. Anil Shrestha has already done few programs in Pure. It's privileged to have again and again because of its knowledge, commitment towards the RIRS. Associate Professor, Program Director, MCH Urology and Chief of Unit 2, Department of Urology, National Academy of Medical Sciences, Bir Hospital. Senior Consultant Urologist, BNP Hospital, Nepal. Secretary General, Nepal Association of Urological Surgeons. Deputy Chairman, Scientific Committee, Urological Association of Asia. Deputy Treasurer, Nepal Transplantation Society. Member, Editorial Board, International Journal of Urology. Organized various live workshops, conferences, and symposiums. In fact, I have been to Nepal. I have been to operative faculty as well as the in their national conference. I have given a talk. Wonderful hospitality and great scientific programs. Nepal is heading towards a very good urology society, and most updated work they are doing now. He performed live surgeries in various national international conferences, publications in national and international journals, special interest in urolithiasis, flexible scopy, RIRS and laser, International Journal of Urology and Nephrology reviewer, invited faculty for many international national conferences, demonstrated live surgeries in conferences. With this introduction, Anil, hello, good evening.
Yes, good evening, Chandra. Thank you for coming.
So after some time we are doing this. Definitely a lot of audience will be there for this common topic. So without wasting time, I will hand over the program to talk on the inferior calyceal stone RIRS. Thank you once again being with us.
Thank you, Chandra, for kind invitations and introductions. It is always my privilege to be a part of Pure Urology. So once again, I'm here. So
yes.
Can you see my slides?
Yes, yes.
Okay.
Nice.
Okay.
Yes.
So thank you, Chandra, once again. Very good evening. Maybe somewhere good morning or good afternoon somewhere in the world. All the Pure Urology friends, warm greetings from Nepal. So today I'll be talking on how to perform retrograde intrarenal surgery or flexible uteroscopy for lower pole stone. So since all the guidelines, all the popular guidelines like European guidelines and American guidelines have shown the established role and established place for the retrograde intrarenal surgery for lower calyceal stones. So I won't be comparing much with the PCNL and ESWL as a role of stone management in lower pole stone. But I'll be talking how to improve or how to do flexible ureteroscopy for lower pole stone and how to make it more efficient and safe. So I don't have anything to declare.
Yeah.
So when we talk about lower pole stone and RIRS, so why we talk about lower pole stones and why don't we talk about upper pole stone or middle pole stone? Because of the axis, the difficult anatomical axis or difficult anatomy of the lower pole stone, one. Second is chances of scope damage, maybe. It is not yet proven, but the fear of scope damage while we do flexible ureteroscopy for lower pole stone. Third is what will be the stone free rate, because lower pole is the dependent part of the kidney. So what we believe that if we powder the stone and we don't evacuate or we don't actively remove the stone fragments from lower pole, then stone free rate somehow may be less than other location. And lastly, ergonomy for the surgeon as well as patients and the scope. So all these factors make a lower pole stone somehow different from stones of other location in the kidney. So we will be talking how to gain the access of lower pole safely and efficiently, how to make stone free rate higher, or does it have anything to do with scope damage, or is it not very friendly for the surgeon's hand? So we'll be discussing these factors, these aspects in today's presentation.
Yeah.
So when we talk about axis of lower pole, so it all depends on the renal anatomy. You know, the renal anatomy as shown by Sampaio is different in different people. So it's not exactly the same for all the people. So it may vary from person to person. So it depends whether we will be able to access the lower pole or not, because renal anatomy will also tell us, or which type of scopes are we using. Like about 2-3 years back, most of us were using reusable scopes. Now I believe now most of us are using so-called limited use or disposable scopes. So fear of scope damage is somehow somewhat little, or it has decreased, I would say, for me. So since we are using limited use scope, they are cheaper, and even if it gets damaged, we can replace with another scope. So I wouldn't say the era of reusable scopes, but around 3-4 years back, we used to have that fear of damaging our very expensive digital scopes when we are doing lower pole stone. So it was believed, or it was said, that digital scopes are somewhere inferior to fiber optic scopes when we are about to access the lower pole stone. So some flexible fiber optic scopes are little bit better than digital scopes, because the end tip deflection of fiber optic scopes are better than digital scopes, because the digital scopes have CMOS technology, or chip at the tip of the scope. So it makes them little bulkier than fiber optic scopes. Again, laser fiber, I believe most of us use the smallest laser fiber that we have in theater for flexible ureteroscopy, especially for lower pole stone, because it may hamper the deflection of the flexible ureteroscopes, and different accessories. And of course, the experience of surgeons also matters when we talk about access to lower pole. So stone free rate may be dependent on the laser settings that we use, whether we relocate the stone or we do in situ treatment of the stone, or high power laser or low power laser, or TFL or Holmium-Yaag laser, which laser machine we use, does it make any difference? Or these days, some of our friends from Singapore, and even from India, they are using active suction during flexible ureteroscopy. So does it make stone clearance better or not? So let's go back to 1992 when Sampaio had reported their work on Endocast, and they revealed that lower poles are not very bad as we think, as they reported, 74% of lower poles are obtuse. They are not very accurate. So they can be easily accessed. And 60% of the lower pole had infundibular width more than or equal to 4 millimeter. And 57%, more than half of the lower poles had multiple calyces. So all these factors indicates that RIRS is quite feasible and quite doable for lower pole stones. So how to access lower pole? If we are approaching lower pole of the left kidney, the picture in the video is showing how to access the lower pole in left kidney. The tip of the flexible ureteroscope should be facing or should move towards the 5 o'clock position, so that sometimes when the lower pole is deep seated, when it is acute, then we may miss the lower pole. So if we pass our scope at the 5 o'clock position after passing the UPJ, then we will be able to reach lower pole of the left kidney. Whereas if we are looking for the lower pole in the right kidney, then we have to go to the 7 o'clock position. So which scope is good for assessing lower pole? It is a little bit old study, I would say. It was published in 2017, and lots have changed after that. Like in 2017, we were using disposable scopes. There are only few disposable scopes in market by Boston Scientific and Pusen. But nowadays, most of us are using disposable scopes of various companies. So this publication or this research carries little value, I would say, but still it's good to know that there is something called end-tip deflection of flexible ureteroscopes. So with the very rigid part of distal end of digital scopes, these digital scopes were believed to be inferior to fiber optic scopes when we want to access the lower pole stone. But nowadays, even the digital disposable scopes are getting slimmer. You can get digital scopes of 7.5 French size. So they are equally good when we want to access the lower pole. So, but there are, as we mentioned, that the lower pole anatomy may vary from person to person. So when we talk about lower pole calyces, as shown in the picture, the calyx B is something like even if it is deep down, it is quite accessible. The scope can be easily reached in the calyx B. But when we talk about calyx A, it is somehow difficult because it is facing anteriorly. So scope has to go down and face anteriorly. So in this kind of situation, we have to know our scope better. So that means that some of our scopes are very good, and the end tip deflection is very nice, so that we can have an active deflection of the tip of the digital scopes to access this difficult kind of lower poles. So we should know our machines better to have the successful access to lower poles. So this is one of the scopes from Pusen. It is 7.5 FR in size. See the end tip deflection. So these deflections are very helpful, not only in lower pole, but even in some difficult mid pole or upper pole when they are not very straight. These deflections are very useful to access difficult calyces and sometimes calyceal diverticular stones. So apart from active deflection of flexible scopes, there is something called passive deflection, which comes very handy when the scopes are not reachable with active deflection, especially when the lower pole stones, lower pole calyx have acute IPA, or the calyx is located very deep down and the systems are very dilated. In this case, only active dilatation may not help us to reach the stone and the desired calyx. So in such condition, we should do passive deflection, which means that the scope is pushed against the wall of the pelvic calyceal system manually, pushed a little bit further and do the deflection, so that all the flexible part of the flexible scopes get deflected and we can reach the difficult lower pole stones and do the lithotripsy.
Yeah. So
there are different types of scopes in the market. Like some scopes have deflections lever that can be left and the scope still remains deflected. Like the reusable scopes from the Karl stores, Flex X2S, it is very useful, or it becomes more ergonomic when we do lower pole stone. Your thumb you can rest your thumb, in between the surgery. You don't have to keep pressing the lever in the lower pole stone surgery. Whereas some scopes from other companies, they don't have this property. So if you have this scope, then you will have a little pain, less pain in your hand when doing difficult calyceal surgeries. So when we talk about access to lower pole, there is something called Infantibular pelvic angle, which was popularized during ESWL era for the stone clearance after ESWL. So there are various methods of measuring IPA. It was first introduced by Sampaio again, but there are different other methods too published from India by NP Gupta sir and Sabnis sir. But the most popular one is reported by Alvanasi, and most of the research are based on Alvanasi technique. But what I think is all these method of measuring IPAs are different, and the angle of IPA described by different authors are different. So there is no standard technique of measuring IPA so far, and it has not been externally validated. So it is difficult to measure. Even if we take the Albanese technique, if I measure and if somebody measures same patient in IVU, then we may get a different measurements. So it is not very reproducible, I would say, and it again depends upon the quality of IBU pictures in CT, whether the patient is well hydrated or not, how many contrast was how much contrast was injected, and how distended is the system. All these can make a difference when we measure the IPA. So IPA still has a doubtful benefit in assessment of whether the access to the lower pole of kidney can be done or not. So with more research and with more publication, I think the role of IPA in lower pole stone with flexible ureteroscopy will be established, I believe, in future. So next, what we should know that anything inside the working channel of the flexible ureteroscopy can decrease the deflection of the flexible ureteroscope and the irrigation flow. So it is said that at least around 215 degrees of deflection of the flexible scopes is necessary to access the lower pole. If your scopes is being overused, or you have an old scope which is not deflected well, if the deflections of your scope is less than 200 degrees, then it is most likely that you won't be able to reach the difficult lower pole calyx, and it is not the suitable scopes for your surgery. So this is the picture to depict that depending upon the accessories in the working channel, the deflection of your flexible scopes may go down. See the empty working channel, most of modern flexible scopes can deflect up to 275 degree up and down. But when we put a laser fiber, it goes a little bit down. With 365 with 365 micron laser fiber, the deflection goes significantly down, whereas with 2.2 FR basket, the deflection is still good. So what we should understand is laser fiber will decrease the deflection more than the basket. So because it is a fiber glass, laser fiber is made up of glass, it will decrease the deflection more. So when we do surgery for lower pole stone, always use smallest laser fiber in your theater. So these days with TFL, we can use even 150 micron laser fiber with TFL. So I think what TFL, apart from being a good laser machine, TFL is providing us smallest laser fiber. It's another benefit of TFL. So is there any laser setting for lower pole? I don't think there are separate or specific laser setting for lower pole, but there was a study, it was again published in 2017. They reported that if you use higher energy with a smallest fiber, then there is a chance of risk of rupture of the laser fiber. But in my personal experience, I haven't seen any breakage of the laser fiber during lower pole surgery. So this is a lab research, lab paper. So in practice, I don't think we are using more than 1 joule of energy in any flexible uteroscopy, max 1.2 sometimes. Otherwise, in dusting, we use maximum of 0.8 and 1 joule. So it is quite safe to use, but higher energy, like total power of more than 25-30 watt, may be dangerous even for stones in another location. So I don't think there is a specific laser setting for lower poles, and the chances of breakage of laser fiber is not reported in vivo actually. So as Chandra mentioned, is there any beneficial role of displacement technique or relocation of the lower pole to improve the stone free rate? I think it has been discussed since we have started flexible uteroscopy for stones. But I don't think we have enough data for that. It is a fact that flexible uteroscopy can convert lower pole stone to non-lower pole stone if we basket and relocate the stone from lower pole to either to upper pole or middle pole. But does it have any beneficial role in terms of stone free rate or in terms of scope damage or for ergonomy to us as surgeons? It is the questions are still not answered, but there are few publications about relocation technique, whether it improves the stone free rate or not. There was a paper by, actually this displacement technique was reported first by Preminger group from United States in 2000. But they had reported only few cases, like 4 or 5 cases, and showed that it was better than in situ fragmentation, but the number was very scanty. So later there was another report from United States again. So there the evidence is very sparse, I would say. The very little. So with that in mind, we had conducted a study in our department, which is recently accepted and published in Journal of Urology, and we prospectively observed and we randomized in 2 groups: in situ fragmentation of the stone for the lower pole, and relocation and fragmentation either in the upper or middle pole stones, and it included around 70 patients. The stone-free rate was slightly higher in relocation group, but it was not statistically significant. The number is not very high, so I think we need a larger study again to prove the benefits or doubtful benefits of relocation. So another question is, do all lower pole stones need relocation? As Sampaio has reported way back in 1992, more than 3/4 of the lower pole stones, lower pole calyces are obtuse. They are not very acute. And the infundibular width are also more than 4 mm. So that itself says that not all lower pole stones need relocation. If you even do in situ fragmentation, if you do good dusting, the dust will clear from the lower pole easily if you have done good dusting. So the answer is not necessary. With the invention of better scopes, the quality of vision of modern scopes are very good. The deflections of the modern scopes are excellent. There are very few cases in my practice that we could not reach the lower pole with the available scopes. But yes, there can be a difficulty in lithotripsy, complete lithotripsy in lower pole stones sometimes. As seen in these pictures, this difficult looking lower pole calyx is easily accessed by the disposable digital scopes. So these days we have very good disposable scopes, very good flexible scopes, and it is getting better day by day. It is getting slimmer day by day, and the laser machines are getting powerful. The introduction of thulium fiber in the urological practice has somehow changed the way we do lithotripsy. So again, the quality of dust also matters when we do lower pole lithotripsy in situ. So all these factors is the good evidence that we don't need to relocate all the stones, each and every stones from the lower pole. Yes, there can be conditions when we need to relocate for other reasons, but routine relocations of the stones from lower pole is not necessary. So in situ dusting, if we do in situ dusting, then if you are not very convinced, or if you have some doubt that there can be a residual stone in the lower pole, then you can gently flush out the stone fragments with a pathfinder or a traxor flow, and you can evacuate the lower pole fragments and make the lower pole free of the stone fragments. These days, friends from Singapore are using flexible ureteral access sheath that can go way down to the lower pole and suck the stone fragments out of calyces during flexible ureteroscopy. Since we do not have a head-to-head comparison of suction and conventional dusting, fragmentation, and basketing techniques in terms of stone-free rate, overall, generally in flexible ureteroscopy and flexible ureteroscopy for lower pole stone, it is too early to say that suction or flexible ureteral access sheath gives higher stone-free rate, but definitely the use of suction will give immediate stone-free rate, and probably the stone-free rate may go higher with suction devices in flexible ureteroscopy. And it may be the future of flexible ureteroscopy, and we may be doing larger stones of treatment of larger stones with flexible ureteroscopy if the suction devices, suction technology is widely used for flexible ureteroscopy. So the techniques are getting better, the scopes are getting better, people are getting trained by different platforms, like there are there are YouTube channels, there are ongoing trainings, so widely available. So people are getting trained better, and the use of different armamentariums like laser fiber, laser machines, these all are making this flexible uteroscopy more acceptable and more efficient. So if we are relocating, somehow if we need to relocate, not for stone-free rate, for ergonomics, like see the picture in the left shows that you may need to do flexible uteroscopy with a very difficult or uncomfortable wrist position sometimes. So in those conditions, we need to relocate the stone to do lithotripsy in more comfortable positions. So while relocating, we have to relocate for good. We have to relocate the stone for better ergonomics. So before relocating, what we have to do is we have to access which calyx is favorable. So sometimes upper calyx are not favorable always, when it has happened to me a couple of times, we relocate the stone from the lower pole and place into the upper pole, but the upper pole appear to be more unfavorable in terms of ergonomics, So access the calyces, do the inspection beforehand, which calyx is more ergonomic, and relocate the stone in that calyx, so that you can do faster lithotripsy and you can finish the surgery faster. So these days, flexible scopes are improvised. As we said, it has better vision, getting smaller. We have better lasers like TFL, high power laser, even 30 watt lasers, Holmium-Yag lasers have better pulse modulations, longer pulse durations, and they are becoming more efficient. We have better accessories like access sheets. We have good basketing accessories, and trainings are readily available, like online platform like Pure Urology and other YouTube channels are available for trainings. All these can make flexible uteroscopy even more safer and efficient. And even for lower pole stone, flexible uteroscopy can be efficiently and safely do the job. Thank you.
That's nice. I thought some more. I was listening carefully. Some more slides will be there, but you suddenly finished. Very good. We have time a little bit about my questions. As a layman, I will ask some questions.
Sure.
When the patient comes to you with an inferior calyceal stone, and he is not very particular about PCNL or RIRS, he says, please remove my stone completely. Then you usually do CT. You don't do IVP in our setup. In private practice, we are doing CT, plain CT, good quality.
Yes.
The reconstructed film. What are the common, forget about angle. We never take the scale. We never take the geometrical, these things to measure, obviously. It is a visual feeling how deep the calyx is. What are these, what are in your mind practically to say that I will be more successful in this case with RIRS? You pay accordingly. This is a practical question I'm asking. And in which cases you say that no, directly go for PCNL? Yes.
So there, as you correctly said, that we generally do not do IVU, CT IVU. So we generally do CT KVU. So we do not go for a measurement of IPU. That's what I do in my practice as well. So first and foremost, the size of the stone, if the size is very more than 18 or 20 millimeter, more than 20 millimeter, then I would routinely explain about the need of second session if he or she insists me for flexible uteroscopy in lower pole stone. Okay. So if I am doing like less than 2 centimeter stone, and if the HU is not very big, and see, even if we do not measure the IPA, even in the plain CT KV, you can make how deep or how the IPA is, If the stone is very near to the ureter or it is medially located, then I assume that the surgery may be little difficult or it will be difficult to access the lower pole. If it is little lateral or towards the lateral edge of the kidney, then I would assume that I will be able to access that lower pole. So these days, even up to 2 centimeter, I do flexible uteroscopy even in lower pole.
As the experience increases like you tend to get to RIRS. What I feel is you go in a general anesthesia or spinal anesthesia, go with open mind, put a sheath and go with flexible scope. If you are seeing the stone all parts without too much flexion on the scope, I'll proceed. If I have a lot difficulty, a stone iceberg is seen and broad base is there and free calyx is not there, I will immediately shift to PCNL. I will take the consent for the both, and maybe I will be charging less if I am going for the PCNL. Do you agree that you should be little broad-minded, sometimes flexible, sometimes on table also 10% chance that you may shift to PCNL?
Yes. I agree, Chandra. When we, I totally agree with the fact that you said that when we do flexible uteroscopy, we tend to see all the 4 corners of the stone so that we can do, successful lithotripsy. But with experience, what I have noticed is even if you don't see one part of the stone, say, let's say medial or lateral part of the stone, with the lithotripsy going on, you can flush the stone with the manual irrigation and you can reach the stone. Even if you don't see one part of the stone at the beginning of the surgery, we can finish the surgery with flexible uteroscopy, I believe. Or if you have done lithotripsy of more than 2/3 part of the stone, and if you can't reach with your laser fiber, then at that stage, I prefer basketing remaining stone out of the lower calyx and finish it in another calyx.
Yes. After some time of lithotripsy, you can relocate and
relocate it. So that will yes, that is another. Yes, Chandra.
Hello.
Yes, Chandra, I am listening.
Anil.
Yes, I am listening, Chandra.
Hello.
I can hear you, Chandra.
Hello.
Yeah, I can hear you.
Anil.
Yes.
Are you able to listen?
Yes, I'm listening.
Anil?
Chandra, yes. I can hear you. Chandra? Chandra, yes.
So we are connected still.
Yes.
Are you able to listen?
Yes, I'm listening.
There is few questions we will take. Connect internet. Hello. Hello.
Yes, Chandra, I can hear you.
Now it's better. So my another question is, sometimes the angle which you think is difficult in RGP also, IVP also, when you go inside, somehow we can reach all the calyces so easily and we can get away. The elasticity of the infantibulum, the distensibility of the calyces also make a gentle attempt, especially in a 1.5 centimeter less than stones, is worth, and most of the times we are successful with the present flexible scopes and laser. Do you agree?
Yes, I totally agree. That's what I was saying in my presentation, that the measurement of IPA is not always correct. It all depends upon the how distensible,
Sometimes,
how distensible was the calyces during CT-IVU. So even if the IPA doesn't look good in pre-op images,
yes,
it's worth going with flexible ureteroscopy, do gentle irrigation, distend the system, and try assessing the lower pole. I think it's worth, because IPA, the role of IPA is still very limited, and there is no good evidence of IPA telling us whether lower pole is accessible or not. I think you are totally right. Chandra, you are muted. Chandra, I can't hear you. Please unmute your mic.
are you able to listen?
I can see you. I can hear you. Is it good now?
Yeah, same thing. No problem.
Okay.
And do you think that the Hounsfield units in inferior calyceal stone is more important? Hounsfield units in inferior calyceal stones is more important than other locations, because even if you are having difficulty, you do popcorn, they will become powder better.
Yes,
Low Hounsfield unit stones.
Yes, I think Hounsfield unit of stone is, I think, understated parameters of stone treatment. I think stones of all the location, I think Hounsfield unit is a very important factor. And as you said that lower Hounsfield unit, you can finish the stone faster, you can do better dusting. And even if you have to do popcorning, then it is more easier with lower Hounsfield unit. I think you are right. I always check the Hounsfield unit, even if the stone is bigger, like let's say 2.5 centimeter. Then if the Hounsfield unit is like 700-800 HU, then I go for flexible ureteroscopy, even for lower pole stone. So Hounsfield unit is an important factor, I would say.
Yes. You have used 100 watts laser also. You have in your unit, Bir Hospital, 100 watts holmium is also available. Do you think that a deep inferior calyceal stones, these 100 watts laser can make some difference?
I don't think a high power laser has any extra benefit in lower pole stone, but with 120 watt luminous machine, there is a property called Moses technology. So in Moses technology, there is a parameter called non-contact laser lithotripsy. They say that even if you don't touch the stone with laser fiber, especially in difficult reachable calyces like lower pole stone, then with Moses technology, the lithotripsy is still possible. But I don't think it is required because the latest laser machines like TFL and even 30 watt laser machine can do the similar job. I don't think 100 watt laser adds any benefit in lower pole stone.
Yeah. If you use 150 micron fiber in TFL, if you increase the energy and frequency too much, will there be any chance of cracking of the 200 micron fiber at the deep angle of the flexible scope?
200 or 150?
Yeah, 150 also, whatever it may be. Previously, we used We used to say that if laser fiber can break at the maximum angle if you use high energy.
Yes. I personally, I haven't used 150 micron. I'm using 200 micron with my TFL. And the reports that I have shown in my presentation that with high power laser, the breakage of laser fiber is seen with thicker laser fibers, not with thinner fibers, like 300, more than 300. Yes, in holmium. Like if you use more than 300 micron fiber with higher energy, then there is a chances of laser fiber breakage, not with the smaller fiber. But in my practice, I have never seen breakage of the laser fiber with higher energy, because I do not use higher laser wattage during lithotripsy. Maximum I use is 25 or 28 watt for all stone location, not only in lower pole.
Yeah.
So have you seen, Chandra, have you seen any laser fiber ruptures during your?
No, I have not seen. I have not seen.
Yes.
It's only theory so far. I am listening. I have never heard of breaking the laser fiber. And last couple of questions. Do you ever incise the infundibulum of the lower pole when you are partly not able to reach some part of the stone to medial?
Yes. Yes, these days, in last couple of months, I have started doing that. But for that, you have to be very, precise, and you have to be very careful where to cut. You do not cut in one place deeply, you know, the infundibular artery may be there. So if the lower pole, not only lower pole, even sometimes middle pole are also difficult to access, you know. So in those cases also, I do cut the infundibulum to do efficient lithotripsy. Yes, I do cut these days.
Achha. So my last question, in case of a lower pole stone, which is more than 2 centimeters, for the juniors, when do they take such case for the RIRS? What precaution they should do they have to use disposable scope? Do they have to be prepared for the relook? Do they have to make it fragments and relocate? In the presence of TFL, can they do popcorn continuously? And is there any chance of mucosal and infundibular injury if you use popcorn for a longer time? So a message last you wanted to give, a large stone lower polar. What is your approach with your maximum experience of 15 years?
So large stone in lower pole, more than 2 centimeter.
Yeah.
I wouldn't say that the first option will be RIRS. Even for me, I wouldn't do RIRS routinely for larger stones more than 2 centimeter. Yeah, lower pole stones.
Great.
Unless there is a contraindication for PCNL. Unless there is a contraindication for PCNL, like coagulopathy, or patient insists to do RIRS, even if they want to do multiple sessions, then only we go for RIRS. Regarding TFL popcorning for longer time and mucosal injuries, yes, not only for lower pole, if you see, when we do popcorning or pop dusting, we tend to use slightly higher energy than normal dusting settings. Like we use more than 25-30 watt for popcorning or pop dusting, especially with TFL and high power holmium YAG laser. So even if you do popcorning with high power laser, holmium or TFL, you have to stop in between. You don't press the pedal for very long. That will increase the temperature, and chances of mucosal injuries and thermal injuries is high. So yes, you have to be careful, not only in popcorning, pop dusting, even for the dusting setting. If you are using higher laser wattage, then you have to be very careful. Do the continuous irrigation. Don't stop the irrigation during popcorning, especially during popcorning. During popcorning, it is very essential to have irrigation going on.
Very good. So with this, we will conclude the session. More than 130 audience have watched the program. I'm really happy, except a few minutes of disturbance, everything went well. And a lot of information, especially you always upgrade your videos, animation videos. Sampio, this thing along with fingertip holding the flexible scope and then it is going up is very good. Every time one new video will come. Enthusiasm, and I wish you all the best for this RIRS surgery in your country, and I wish you will become an international faculty sooner. Thank you very much, Anil.
Thank you, Chandra. Thank you for the invitation. Bye-bye.
Hello,
Bye-bye.
Anil. Just stay back 1 minute.
Yes.
I'm going offline.
Yes.
Just stay back 1 minute. Yeah, we are offline.